Welcome to another case review. Here our topic is going to be a patient with a chief complaint of, "I think I broke my arm." A 52-year-old man presents to the ED with his wife complaining of right arm pain. 2 hours ago he fell out of his bed and immediately felt excruciating pain which has not gone away. He says he thinks he's broken his arm. The patient is otherwise healthy and there's no significant past medical history. Medications include ibuprofen for intermittent back pain, which he's taken for the past year. Physical exam reveals a range of motion of the right arm, which is limited due to pain. Radiograph of the arm confirms fracture to the right humeral shaft. There are several lytic lesions visible along the humeral shaft and distal epiphysis. So here's our radiograph, and you can see that there's a pretty obvious fracture here. Now you always want to get two views anytime you suspect a fracture. But here's our fracture line. Now this might, if you just had this view here, you might think that this is just a simple fracture. But if you look here, you can see that you have a fracture that not only is diagonal, but it extends down distally down the humerus. So this would be an oblique fracture. So we have an oblique fracture. We also see these lytic lesions, definitely very obvious on the more distal part of the humerus, but they extend upwards, probably about as far up as the proximal 1/3 of the humerus. So you have quite a few of these lytic lesions. They're a little bit more obvious if you see them with greater magnification, but this is pretty clear lytic lesions here. So our assessment is a displaced oblique fracture of the shaft of the humerus on the right arm and associated osteolysis. Our differential is anything that can cause a fracture, so trauma or pathology. Well, we definitely had trauma here, but when you're trying to distinguish between traumatic fracture and a pathologic fracture, what you want to take into consideration is the degree of the trauma. So this guy just fell out of bed. Do we expect to have a broken humerus every time we fall out of bed? Absolutely not. Now, if the vignette was he fell off a 12-foot ladder, then absolutely we would expect to see a broken humerus. Okay, that would not be suspect at all. If you got into a motor vehicle accident, something like that. But falling out of bed, not so much. Now we also know that he's got lytic lesions, so that's a dead giveaway. This is a pathologic fracture. So some of the things that cause pathologic fracture are things like primary osteoporosis. Do we suspect that in this guy? Well, he's got lytic lesions, but otherwise would we suspect it in this guy? No. Osteoporosis is usually something that happens in postmenopausal women, and he is not only not postmenopausal, but he's not a woman. Okay, you've got to be a woman to be postmenopausal anyway. So what about secondary decalcification of the bone? Probably, because he's got lytic lesions. But lytic lesions can also be from metastasis. That is a possibility. You can also get decalcification from cancer that's not metastasized. But it's probably not metastasis because he has no history of cancer. But we can't rule it out. Okay, so we're going to need to get some more tests. So our initial workup is going to be a CBC, a BMP chemistry. We want to get a serum calcium level, we want to get a serum albumin level, and then we want to get a urinalysis. And what do we see? We see a hemoglobin of 7.5. High, low, or normal? That is low. So when you see a low hemoglobin, the very first thing you should do instantaneously is check the MCV. That should be a reflex. And we see an MCV of 90. High, normal, or low? Normal. MCV 80 to 100. Okay, so MCV is 90, so this is a normocytic anemia. Very important on the test that you have some kind of awareness of microcytic anemia, normocytic anemia, macrocytic anemia, the most common causes of that. Microcytic, iron deficiency. Normocytic, anemia of chronic disease. Macrocytic would be something like folate or B12 deficiency. You need to have that differential. You need to know what kind of anemias are due to what. Or what kind of anemias are associated with what kind of MCV. So this is a normocytic anemia. Could be anemia of chronic disease, could be a plastic anemia, we don't know. Hematocrit of 22.9, what we would expect with a hemoglobin of 7.5. Usually it's about triple the hemoglobin. White blood cell of 5.5. Normal, high, or low. That's normal. It's on the lower end of normal, but it's normal. Platelets are are normal. So we have an isolated red blood cell anemia. Uh, what about our chemistry? Sodium, potassium chloride, bicarb, they all look good. BUN creatinine, though, his creatinine is high. Okay, 2.1 is high. So what you'd want to do is you'd want to look at his previous creatinine results to see if this is an ongoing renal issue that he's got. And then the other thing you want to do whenever you see a high creatinine is you want to do a BUN creatinine ratio. So that's just dividing the BUN by the creatinine. And if we were to have a BUN creatinine ratio of 25, so let's say that his BUN was 50 and his creatinine was 2.1, then we would expect acute or pre-renal disease, so possibly dehydration. But this BUN creatinine ratio is about 15, and that is suspect for some kind of intrinsic renal issue. Serum calcium 11.6. That is on the high end. Okay, so normal would be up to 10.5. So 11.6 is high. So he's got hypercalcemia. Asymptomatic hypercalcemia, as far as he's got bone signs, but otherwise asymptomatic. He doesn't have any neurologic signs or anything like that. Serum total protein is 8.2, so this is high. And the urinalysis shows trace protein. That's not unusual, but when you take that into consideration with his BUN creatinine ratio, his elevated creatinine, his serum total protein, and then this trace protein, that's suspect for something going on with the kidneys or something going on with this elevated total protein, which may be affecting the kidneys. Hint, hint. All right, so from there, here's our laboratory impressions. We have normocytic anemia, hypercalcemia, renal impairment, hyperproteinemia. So whenever you have labs, you want to just write down on your note what you see from the labs, your laboratory impression. It'll just make it easier to brainstorm what our differential is. So we're going to do a further workup. So we have hyperproteinemia, and we have a little bit of protein in the urine. We also have renal issues. So put all that together. What do you think that might be? Well, you should form your differential. Do we have? Okay. You should probably form your differential before you do further workup. But anyway, you can brainstorm a differential from what we've got. We're going to get a urine protein electrophoresis, a serum protein electrophoresis. We want to get a 24-hour urine protein. Why? Well, because he had a trace proteinuria. We don't necessarily know the extent of that. It's possible to have a trace proteinuria, but have actually more protein in the urine than we detect on dipstick. So we want to get a 24-hour urine protein because a 24-hour urine protein is much more definitive as far as determining how much protein we actually have in the urine. We want to get a serum free light chain assay and a beta-2 microglobulin. So all of these things are good to get whenever you have new renal disease. Okay, this would be a good workup for anything, any kind of new renal disease when you don't really know what the cause is. Okay, and what do we find? Urine protein electrophoresis shows a positive Bence-Jones protein. Oh, gee, there's a diagnosis, right? Serum protein electrophoresis shows a monoclonal spike in IgG at 6.5 grams per deciliter. 24-hour urine protein is 5.8 grams. What's the normal 24-hour urine protein? Less than 100 milligrams. Okay, so this is really high. Now, why did we have a trace protein on the urinalysis, but this 24-hour urine protein, which is through the roof? Well, Bence-Jones protein does not register on urine dipstick, or if it doesn't register very much. So it does register on 24-hour urine protein. So this is probably a lot of Bence-Jones protein in the urine. Serum-free light chain assay shows increased kappa and lambda light chains. That's consistent with the immunoglobulins in the serum, and then the beta-2 microglobin is increased. So our differential diagnosis is going to include multiple myeloma, monoclonal gammopathy of undetermined significance, smoldering myeloma. All three of these things are these gammopathies. Okay, so we don't know which one it is. There's a test that we can do to determine it. And then Waldenstrom's macroglobulinemia. Now, it's probably not Waldenstrom's macroglobulinemia, because Waldenstrom's is associated with a IgM spike. It's not associated with an IgG spike. Furthermore, there are other symptoms that are associated with Waldenstrom's that are not associated with these monoclonal gammopathies. And that would be things like increased cold agglutinins, hyperviscosity. So this is probably not Waldenstrom's. But I included it here just to kind of differentiate that out. Because Waldenstrom's is also a plasma cell disorder. And it does cause increased immunoglobulins in the serum. So we need to get a bone marrow aspirate. Anytime you suspect possible multiple myeloma, you need to get a bone marrow aspirate because that will help you determine whether this is smoldering myeloma or multiple myeloma. Now, it's not going to be of undetermined significance because of the level. It's 6.5 grams per deciliter. Monoclonal gammopathy of undetermined significance, or MGUS, has got to be below 3. So this would probably not be MGUS. Smoldering myeloma and multiple myeloma, the difference is symptoms. So we're going to get a bone marrow aspirate, and what we find is infiltration of marrow with plasma cells constituting approximately 21% of the marrow cellular population. So we have a diagnosis of multiple myeloma. Our treatment plan is going to refer to orthopedic surgery for fracture repair, which the surgeon will determine what kind of fracture repair he or she wants to do. That can be closed reduction with percutaneous pinning or open reduction and internal fixation. We also want to refer to heme-oncology for the treatment of the myeloma, and there are a variety of, which we're going to talk about, there's a variety of treatments that can be done, treatment regimens. That goes for a lot of different cancers. And as a matter of fact, with multiple myeloma, the possibilities for treatment regimen is so diverse and there's so much disagreement on what is ideal. We don't really even know what's ideal, and there's new drugs that have come out, and there's just a lot of conflict and disagreement as to what's the best. So you're probably not going to be tested this on the USMLE. I would highly doubt you'll be tested this. However, it's good to know what some of the drugs are because there are kind of a limited number of drugs. It's just the question is what drugs we use and when. And there are some kind of established drugs, but I don't expect you're going to be asked this on the USMLE. Autologous stem cell transplantation, this patient would be a candidate, but we'll talk about what sort of goes into determining that. A skeletal survey plus or minus radiation, you want to look at all his bones so you can see if there's lytic lesions in other bones because those bones will be susceptible to fracture. Radiation can be done to get rid of those lytic lesions and reduce the risk of fracture. And then monitoring. So we're going to talk about all these things. So multiple myeloma is a clonal proliferation of plasma cells in the bone marrow, which results in the production of abnormal antibodies. Those abnormal plasma cells actually secrete a factor which causes the osteoclasts, remember that breaks down bone, causes those osteoclasts to become activated. And so what happens is you have an imbalance of osteoclasts, which break down bone, and osteoblasts, which make bone, and so that's why you get those lytic lesions. The immunoglobulin and light chain deposition in the renal tubules is what causes the renal disease. So that's an intrinsic renal disease, and that's why its BUN creatinine ratio was around 15. Which suggests an intrinsic renal disease. It's not over 20. That would suggest something like dehydration. So he has an intrinsic renal disease, and this is due to deposition in the renal tubules. It just clogs them up. And then anemia is going to be seen due to bone marrow crowding. Okay, so you have all of these plasma cells, which are just proliferating nonstop, and it's crowding out the other precursor cells, including the erythroblasts, including, it may include other cell lines, so lymphocytes, it may include precursors to platelets, which are megakaryocytes. But we saw normal results for as far as that went. So you're not necessarily going to see deficiency in all cell lines, but if you do see deficiency in one cell line, it's usually going to be the red blood cells. 1% of all cancers, multiple myeloma is 1% of all cancers, but 10% of all hematologic malignancies. Okay, so I know this is not the best resolution here, but I found this online, and I thought this was a really good picture here. So the multiple myeloma is really a spectrum of disorders. We've already kind of talked about that. The monoclonal gammopathy of undetermined significance, smoldering myeloma, and then the multiple myeloma. Here it says symptomatic myeloma, which is basically what multiple myeloma is. It's a symptomatic myeloma. The difference between smoldering myeloma and symptomatic myeloma, they both have an elevated, a very high fraction of plasma cells in the marrow. The difference is that symptomatic myeloma is symptomatic, that's multiple myeloma, and smoldering myeloma does not have one of those defining symptoms. So plasma cells, they spit out factors which activate osteoclasts and also happen to reduce the activity of osteoblasts. That's what leads to lytic lesions, and that's also going to cause hypercalcemia, because if you are dissolving bone, well, that calcium has to go somewhere, and that calcium is going to go into the blood, and now you have hypercalcemia, and that hypercalcemia can get quite high, and that can lead to symptoms of hypercalcemia aside from broken bones. So the broken bones are really not so much a symptom of a hypercalcemia so much as it's a symptom of bone demineralization and this osteoclast activity. But you can have other symptoms of hypercalcemia. That would be, remember, your mnemonic: stones, bones, abdominal moans, and psychiatric overtones. So you can get kidney stones, which would worsen your renal dysfunction. You can get abdominal pain. You can also get psychiatric issues from the hypercalcemia. And that would be things like slowed cognition and stuff like that. Okay, so what about this stuff going on with the kidney? Well, you're spitting out all these plasma cells. Remember what plasma cells do, is they make immunoglobulins. And when you're spitting out immunoglobulins left and right, what's going to happen is that these are going to leave through the kidneys, and they're going to deposit. And as they deposit, they clog up the renal tubules, and they ultimately will cause damage to the renal tubules, which is going to lead to a loss of protein through the kidneys and ultimately renal failure. So most of this protein is actually little bits and pieces of immunoglobulins, which is what we call the Bence-Jones protein. So that's a Cas nephropathy, and you'll be able to see that on your analysis. The proliferation of plasma cells in the bone marrow will crowd out some of the other blood precursors, and that can cause anemia, leukopenia, and thrombocytopenia. But usually you're going to see the red blood cell anemia. And then because you have all these abnormal plasma cells, which are not making antibodies in response to infection, you're actually also going to sort of crowd out normal plasma cells. And so you're going to be making less antibodies to things you need to make antibodies for. And so you can get recurrent infections, not only due to leukopenia from crowding out neutrophils and things like that, but you can also get recurrent infections because you're not making the correct plasma cells in response to an infection. So if you were to get an infection and you needed to make antibodies for that, because you're so crowded with these abnormal plasma cells, which aren't doing anything important, you're not going to have an antibody response, an appropriate antibody response, and so you're going to also be susceptible to antibody-mediated infection. So infections which you would need antibodies to eliminate. So here it says abnormal function and suppression of normal immunoglobulins, and that's just due to the fact that you're crowding out with all these abnormal plasma cells. You can also get amyloidosis and hyperviscosity, similar to what you see in Waldenstrom's, although this is less rare. If you see, this is more rare. If you see hyperviscosity, you should suspect Waldenstrom's. but it'll be easier to diagnose that just based on what kind of immune globulins you have. With Waldenstrom's, you have IgM. With multiple myeloma, it's IgG. That's why we call it a gammopathy, because it's IgG, G for gamma. I'm not sure if that's where it comes from, but it helps to remember that. Okay, so one of the mnemonics you can use for multiple myeloma is CRAB, C-R-A-B. And C stands for hypercalcemia, which is due to the lytic lesions, the increased osteoclast activity, demineralizing bone, spilling calcium into the blood. Renal impairment due to deposition of light chains and immune globulins in the kidney, resulting in tubular dysfunction. Anemia due to crowding out of the bone marrow, and which is going to result in decreased proliferation of the other cell lines. And bony lesions due to increased osteoclast activity. So here you can see diffuse lytic lesions of the sacrum as well as of the femur. So it's just kind of this almost like ground glass appearance. You have all these lytic lesions. If you look really closely, you can see the individual lytic lesions, but there's so many that it's almost just confluent. Okay. Here's another way that they will show it to you. You'll be able to see these lytic lesions here in the skull. Not sure to what degree these are going to be symptomatic, although a lot of the lytic lesions, they'll give you some bone pain too, even if they're not fractured. This is a favorite of the USMLE. They like lytic lesions of the vertebra. So you can see them here as well. And ultimately this can lead to compression fractures, and that's going to be severe bone pain. So this patient had some back pain, and he's taking ibuprofen for it. And so maybe he's got lytic lesions of the vertebra, and that's what's causing his back pain. So this is a bone marrow aspirate. Unless you're taking USMLE Step 1, you don't need to know this, but this is a normal bone marrow aspirate. You can see just a wide variety of precursor cells as well as some mature cells, so cells in different stages of development. So you can see some more mature-looking segmented neutrophils here. You can see some what look like sort of developing red blood cells. And this is just an aspirate. This is not a biopsy, so you're just going to see the cells here. You can see also some fat globules here, which you do see in the bone marrow. So where are our plasma cells? Well, they're right here. These ones that look kind of like a fried egg. Okay, right here. All right. So this would be a bone marrow aspirate of somebody with multiple myeloma. And the pathologist is going to look at the plasma cells and just kind of quantify them to determine a percentage. You don't need to know how to do that. But they'll count the number of cells and then count the plasma cells and then determine a fraction. So again, these plasma cells look kind of like fried eggs. And you just see tons and tons of them. So these are all plasma cells here. So if you look, the difference here you see a very diverse set of cells. Here you see just lots of plasma cells. Again, this is kind of a similar magnification to our normal here. You can see you're just crowded out with plasma cells. So this is our continuum here, going from monoclonal gammopathy of undetermined significance to smoldering myeloma to multiple myeloma. And with monoclonal gammopathy of undetermined significance, what you see is an M spike. But other than that, everything's normal. So you see the M spike, but there's no symptoms. It's unusual to really diagnose the monoclonal gammopathy because there's no symptoms. And so we don't often diagnose this because there's no reason to get a urine protein electrophoresis, serum protein electrophoresis, because there's no symptoms. But occasionally it is diagnosed. So you just see an incidental M spike, and then if you were to do a bone marrow biopsy from there, you would see a less than 10% plasma cells. So everything looks normal except for this M spike. People with MGUS are at increased risk for developing multiple myeloma, but otherwise they're asymptomatic, they're fine, we don't really do anything for it other than observation. Smoldering myeloma, everything looks like multiple myeloma, except they don't have symptoms. Okay, so they've got an M protein greater than 3 grams, so it's an M spike. They have, if you get a bone marrow, they do have everything looks like multiple myeloma as far as our objective qualities, but they don't have any symptoms. And then multiple myeloma, they've got all that stuff and they have symptoms. So that would be something like a fracture, for instance, or renal disease. Okay, so this is the real-life treatment for multiple myeloma. Now, I want to preface this by saying that there is a lot of disagreement on what the exact treatment for multiple myeloma should be. Now, unlike non-Hodgkin's and Hodgkin's lymphoma, where you're expected to know that non-Hodgkin's is R-CHOP and Hodgkin's is ABVD, for multiple myeloma, there's so much disagreement and so much stuff we don't know, and so many different drugs that may be used in different combinations, and just the studies are so inconclusive, and different oncologists will have different opinions, that you will not be expected to pick out a treatment plan for somebody with multiple myeloma. What the USMLE is going to want you to know is they're going to want you to know when to suspect multiple myeloma, how to diagnose it, and what the complications are. So this is one treatment algorithm that I found from a particular author that I thought kind of reflects a sort of average view. Now, one of the things that you do need to know as far as treatment goes for multiple myeloma is that the best treatment you can do for a patient with multiple myeloma is a stem cell transplant. And typically, the way we determine eligibility for stem cell transplant is age. So anything really above 70 is going to be too old for stem cell transplant. And I say typically because, again, there's some disagreement. And really, anything below 60 is going to be a pretty good indicator of eligibility for stem cell transplant. But there's disagreement. So if the patient is eligible, we put them on a pretty intense induction regimen. And the reason we need to be intense about it is because we need to just totally obliterate all of those myeloma cells, because if you have a decent amount of myeloma cells, of these abnormal plasma cells, then you can give stem cell transplants all day long, and those myeloma cells are just going to come back, and you're going to be right back where you started. And that's one of the reasons why we kind of use an age cutoff, is because by giving these really intense drugs, you do run the risk of complications. And what we find is that patients who are over 70, they're more likely to die from or have really severe complications from the drug regimens which would be given for induction than benefits that we would get from stem cell transplant. So that's probably what's behind sort of that age cutoff. Either way, stem cell transplant is the best therapy that you can get if it works. So if they are eligible, you do an induction. Usually it's with 3 drugs, but again, you can see this author gives 4 different regimens that could be used. And then they do the stem cell transplant, and then there's a consolidation and maintenance phase. Now, the new drug on the block is bortezomib. It was approved in, I believe, 2008, so I think it's not as new anymore. But it's a good drug because, unlike some of the more conventional drugs like thalidomide and lenalidomide and even some of the older, there are some vinca alkaloids that are used occasionally, bortezomib is very easy on the kidneys. And as you know, a lot of patients with multiple myeloma have some renal dysfunction. So bortezomib is given more and more frequently. Now, if they're not eligible, the regimen is typically melphalan and steroids. But it's been ascertained a little bit more in the literature in more recent years that adding a third drug like thalidomide or lenalidomide is actually does improve response for these patients. Okay, so older patients, typically it's melphalan and steroids. Okay, so this is what this particular author has determined is the best therapy for multiple myeloma patients. But you're not going to be expected to devise a treatment plan. Now, what I did is I scoured the literature. I looked at all these different authors and what they recommend, and I kind of put together what, if you were theoretically to be asked a question on treatment on the USMLE, what I would think would be the most appropriate answer. Now, I am not an oncologist. I do not give chemotherapy drugs to patients, so please take this with a huge grain of salt. So, the age cutoff, there's disagreements in the age cutoff. Some people will say you shouldn't do stem cell transplants below 60. Some people will say you can give it up to 70. And some people actually say it's even further. So I put 65. There are some people that say 65. I like that because some people say 60, some people say 70, some people say 65. 65 is a good, happy median. So less than 65 years of age, you go after a stem cell transplant. You will induct with bortezomib, lenalidomide, and dexamethasone, but there are different ways you can go. But bortezomib is really good, and I like it as an answer choice on the USMLE because it's very easy on the kidneys. Okay, with bortezomib, and it is a proteasome inhibitor. That's the class of drug. But with bortezomib, one thing that is recommended, and that you may get pimped on if you're following an oncologist, but bortezomib, you need to give a prophylactic acyclovir. And because there's an increased risk of viral infections with bortezomib. So induction, bortezomib, lenalidomide, dexamethasone. You do the stem cell transplant, and then you can do a maintenance with a lower dose of these three drugs. Okay, but again, please take this with a grain of salt. Oncologists will disagree, or they'll take different approaches. And part of what may be behind that is when the oncologist gets the multiple myeloma patient, they're going to take that bone marrow and they're going to do studies on it. And they're going to look at cytogenetics, and they're going to look at all these different things. They're going to look at patient factors. Does this patient have how bad is this patient's renal disease? If they don't really have much renal disease, they may not use bortezomib. They may use something else. If they have severe renal disease, bortezomib is probably a better option because it's easier on the kidneys. So from there, the oncologist may come up with a different treatment plan. And this is why I don't think you're going to be asked this on the USMLE. I highly doubt it. And all the questions I've ever looked at on USMLE, Step 2, Step 3, I've never seen a question which is asked for the treatment plan. And again, that's unlike things like AML, ALL, Hodgkin's, non-Hodgkin's, where you do need to know something about the treatment because there's wide agreement there. On the other hand, patients who are not candidates for stem cell transplant, it's melphalan and steroids. That's pretty agreed upon. So melphalan is commonly given to patients who are not candidates for stem cell transplant. However, in recent years, it's been suggested that adding thalidomide or lenalidomide onto the melphalan and steroids does improve response. You may or may not do maintenance with these patients. So after you give induction to reduce the bulk of the myeloma cells, you may give thalidomide as an ongoing maintenance, but remember that one of the side effects of thalidomide is peripheral neuropathy, and the longer you give it, the worse it's going to get, the more likely you are to get neuropathy. And so some patients may want it, other patients may not, and the oncologist will make that decision in consort with the patient. Supportive. Okay, so this is more, I think, more useful for the test because all of these things are things that you see in all sorts of different patients, and these are ways that you may approach these complications. And so this is probably a little bit higher yield. You would think that the treatment plan would be really high yield, but it's really not because there's disagreement. But as far as supportive therapy, this is more, there's more consensus here because this is how we treat these sorts of complications even in the absence of multiple myeloma. So starting with hypercalcemia, you're going to treat this the same way you treat hypercalcemia in anybody, regardless of whether they have multiple myeloma or not. You may be asked in the USMLE, got a patient coming in, hypercalcemia and symptomatic hypercalcemia. What do? The first thing you need to do is hydration. Hydration, hydration, hydration for hypercalcemia. Hydration is the first step for hypercalcemia. You may add loop diuretics, but if you're given a list of answer choices for treating a patient with symptomatic hypercalcemia and loop diuretics is one of the choices alone, don't do it. Yes, loop diuretics will help lower your calcium level, but patients who are hypercalcemic often are dehydrated. So you need to give hydration, and then you can add loop diuretics onto that once you make sure that they're well hydrated. So hypercalcemia, give hydration, plus or minus loop diuretics. Bone pain, oh, by the way, do not jump to bisphosphonates for hypercalcemia. That may be tempting because bisphosphonates are very potent reducers of the blood calcium, but do not jump to bisphosphonates. Okay, hydration is your first step, always, always, always for hypercalcemia. Bone pain and fractures, what do you do for that? So for bone pain and fractures, you need to do surgical repair if it's especially if it's a displaced fracture, like in our patient. And then if there are lytic lesions, and this is why we typically do a skeletal survey to look for all of where these lytic lesions may be, you can do radiation, and radiation will kill off the multiple myeloma cells, and it will help with it'll help with these lytic lesions and reduce their risk of fracture. So you can do surgical repair and local radiation. Surgical repair, obviously, for already existing fractures, local radiation for these lytic lesions. Bisphosphonates will reduce your risk of fractures because they help maintain bone calcification. Renal failure, hydration. Now you might think, well, gee, renal failure, patients with renal disease are susceptible to hypervolemia and stuff like that. Why do we give hydration to patients with renal failure? I'll tell you why. Because the patients with multiple myeloma who have renal failure, the reason that they have it is because they've got all those light chains and immune globulins clogging up their renal tubules. And so what the hydration is doing is it's flushing the tubules. So you're getting all that junk out of the tubules. And so hydration will be useful. You want to make sure that your myeloma patients are staying well hydrated. Another thing that you can do is plasmapheresis. That should be one word. But plasmapheresis will take off a lot of those immune globulins and light chains because they exist in the serum, and plasmapheresis is just serum exchange. Infections, it's really just vaccinations and vigilance. So you want to make sure that they're vaccinated to things like streptococcus, Haemophilus influenza. So that's going to help, because remember that some of the things that can go wrong in patients with multiple myeloma are antibody-mediated infections, so infections that require antibodies to clear them. And so the prototypic one is streptococcus. So you want to make sure that they're vaccinated. You want to max out their vaccinations. And you also want to give them varicella zoster too. But vaccinations, very, very important, because it will help reduce their risk of infections. Now remember that vaccinations do require the ability to make antibodies, which is going to be impaired in some patients with multiple myeloma, because if they have a really big bulk, they're going to have reduced antibody formation, at least a reduced normal antibody formation. And so their response to the vaccinations may not be ideal, but you should still give it because it does reduce their risk overall, even though you may not have an ideal response to the vaccinations. And then vigilance. You want to make sure that they are aware of any sign of infection, because these patients will need to be admitted and monitored very closely. So they are at risk, increased risk of infection. So vaccinations and vigilance. Anemia. So typically we reserve treatment of anemia for patients who are symptomatic, but that doesn't take a whole lot, just fatigue and pallor and stuff like that. If they're below 10 grams per deciliter, you can give erythropoietin. Now you might think, well, erythropoietin, why are we giving that when this is a bone marrow problem? You're certainly not giving erythropoietin in patients who have aplastic anemia. Well, the reason that we can give erythropoietin in multiple myeloma is because there is nothing wrong with the red blood cell precursors. The problem in multiple myeloma is that those red blood cell precursors are being crowded out by the myeloma cells. And so if we give erythropoietin, it's going to stimulate those red blood cell precursors and help them compete, if you will, with the myeloma cells. So erythropoietin does help to some degree. You'll give it for 6 to 8 weeks. If there's a response, good, you can continue giving it. But if there's no response after 6 to 8 weeks, because there are some side effects from giving Epogen, you will discontinue it if there's no if there's no appreciable increase in their hemoglobin. Okay, so please take this with a grain of salt. The supportive treatment I did get from a reliable resource for studying for step 3. So this would be good to know. I would remember the supportive therapy for multiple myeloma because you may get a vignette which tells you that the patient has multiple myeloma and then gives you one of these complications. They're coming in with decreased cognition and a recent history of kidney stones, all that stuff. They're hypercalcemic. They have a calcium of 13. You may get a vignette like that, or you may get a patient who's got infection, or you may get some complication in the setting of multiple myeloma, but I highly doubt you will be asked to know a treatment plan for multiple myeloma. Okay? So these patients are going to be monitored every 2 to 3 months, typically with a hemoncologist, and they will get these labs every 2 to 3 months, and what you're really just doing is monitoring for complications, which may be asymptomatic complications, but you want to get ahead of it, and then monitor their response to their chemotherapy. So you get a CBC, obviously looking for anemia and neutropenia. You'll get chemistries and serum uric acid. The chemistries are mostly you're looking BUN creatinine, and the serum uric acid is also a good surrogate for renal function. So you're looking for renal function here, which we want to improve, and hopefully improves, because as you reduce the bulk of the myeloma cells, you should reduce the amount of immune globulins that are clogging up the tubules and causing your renal dysfunction. Serum calcium, of course, you want to monitor for hypercalcemia. You'll be getting a serum protein electrophoresis, looking for that M spike, which we, again, expect to not necessarily resolve, but we expect it to diminish. The serum beta-2 microglobin is a good surrogate for the efficacy of therapy and for prognosis. So the lower that is, the better. And then same with the serum LDH. So these 6 labs are often going to be done for monitoring every 2 to 3 months. If there's new bone pain in a patient with multiple myeloma, you want to get an X-ray. So you're looking for lytic lesions. And then if it's severe, then that means that those patients are going to be at risk of fracture at that site. And so you can do irradiation, and that will reduce their risk of fracture. Now, you may be asked on the test, what kind of imaging do you want to get? And I don't expect you'll be asked between X-ray, CT, and MRI, because those are all equivalent. But you may be asked between X-ray and bone scan, for instance. And you might think that a bone scan is really good, because a bone scan really looks very closely at the bone. But bone scans only will be good for looking for osteoblastic activity, and that's not what we see in patients with multiple myeloma. We see osteoclastic activity, these lytic lesions, and bone scan is not so good for that. So an X-ray, just plain radiographs, will suffice. The prognosis for multiple myeloma, the median survival is 2 to 6 years, but it's definitely improving. It's improving with better therapy, improving with better monitoring, and so we expect this number to go up. But as it stands right now, the median survival is 2 to 6 years, and that's going to depend a lot on the stage, how early it's diagnosed, their complications, how bad their renal disease is, any infections that may come about, and so forth. So as of 2016, the median survival is 2 to 6 years. And that's all I've got for you. If you have any questions, please write a note in the comment section below, and I will try to get to those. Otherwise, I will see you next time.